And currently we'll have around 170 medical centers around the country. So it is pretty big. So overview of what we're going to do today, we're going to talk about it's the importance of sleep medicine in the VA populations, which is really huge. It's one of the biggest topic in the healthcare and VA system. The structure and protocol of how we manage the OSA, how we manage the team approach in San Francisco. We probably one of the very few VA center in the country that implemented dental sleep medicine in the whole program, and for sure probably one of the largest if there's any. We're going to talk about how we're going to refer the patients, how we're going to initiate the diagnosis, and how we're going to refer the patients. And we have a really good supporting team structure set up within our whole system here. And how we're going to manage the disease dentally and also surgically. And then circle back and forth how we treat the patients together. Also, TMD and OSA dual diagnosis is a really important subject in our clinic. So everybody's on the same platform. We manage the patient from the physicians to sleep physician to primary care to ENT, surgeons, dentists, they're all in the same platform. It's just actually a really good system to treat sleep. And everybody, you can see all the notes, everything that's been going on. Area outside the VA, and also the benefits of working within the VA, and also the opportunities outside the VA in the private settings, and how can we utilize this VA system to help the private sector. And we're going to reserve some time for question and answers afterwards. So then next we have Dr. Silva.
Okay, good morning everyone. Oh, thanks. So as Chris was saying, the sleep medicine is really important within the VA, and I think maybe some of you were involved at the VA medical system, the healthcare system, and so you would know also about what a big problem sleep apnea is among the veterans. This is, of course, nationally a giant problem as well. Within the VA, veterans, while they're in the military, might get a service-connected disability rating for sleep apnea, and then, or maybe after discharge from the service, might get diagnosed with sleep apnea and try to claim that as a disability through the Veterans Benefits Association administration. So claims for sleep apnea rose dramatically in that 5-year period between 2009 and 2014. Medical benefits related to sleep apnea grew by 61%. Over 1.5 million veterans have been diagnosed with sleep apnea and are receiving treatment. And you can see also, more than 9 million veterans are actually enrolled in the VA system, and the number of patients are growing dramatically, as on the graph here. So the other big diagnosis within the VA is post-traumatic stress disorder. Everybody's heard about that, and current estimates are that up to 75% of veterans with PTSD have sleep apnea or some sort of sleep disorder, but usually a sleep apnea. Now, within the VA, the VA was not prepared for all of the claims about sleep apnea, and there were initially and still are limitations to the access to sleep care, long wait times resulting in the need to fee some of this out to the community. High costs, lack of standardization, and of course, if you've worked at the VA ever, you see that what happens in one VA is not necessarily what happens in another VA, so there's like this silo effect. Initially, telehealth was not widely available. It's getting better. and all sorts of other barriers. Patients didn't know that certain services were available. Referrals between specialists within the VA were slow or maybe non-existent in the beginning. So the number of sleep consults gone up every year, year upon year, and it's still growing. Now, among veterans, you could see that sleep-related breathing disorders just took off dramatically, and the feeling is that veterans as a whole are very vulnerable to sleep disorders. Other sleep disorders are also on the rise, but sleep-related breathing disorders is number one. And I'd like to examine the reasons why this is. Within the VA, there's a large number of veterans that were related to the Gulf War and other wars. And this one in the Gulf War resulted in something known as Gulf War syndrome. And you've probably heard about this, also known as a chronic multi-system illness that includes respiratory disorders, sleep apnea, of course, fatigue, musculoskeletal pain, cognitive problems, rashes, diarrhea. And this particular group of veterans who were involved in the Gulf War, they have the highest incidence of sleep apnea. Why is that? Because this group of veterans was exposed to sarin nerve gas. They were exposed to biologic weapons, the toxic fumes from burning oil wells, depleted uranium, pesticides. Even the vaccines that were given to soldiers were contributory. And of course, the physical and psychological stress. And all of this put together resulted in this explosion of sleep-related disorders, but sleep apnea was number one. And then another huge number of veterans involved in the Iraqi War. Operation Enduring Freedom, Operation Iraqi Freedom, and other operations after that. 1.9 million US military personnel who, after discharge, came into the VA system with high rates of PTSD, traumatic brain injury, depression and anxiety, and all of this led to high incidence of sleep disturbances, including OSA, excessive awakenings, daytime sleepiness. So all of these veterans are now in the system, and it's a bit overwhelming. Other factors in the development of sleep disorders among military personnel disrupted sleep patterns. Of course, if you're serving in an inhospitable or threatening environment, you're not getting sleep. So there's limited opportunities for sleep due to high operational demands. You have to be up at all hours, be ready to go. And you're conditioned to have hyperarousal or hypervigilance. And this persists after deployment. And of course, a lot of these soldiers went into deployment after deployment after deployment. And so this becomes a lifetime condition. There are some differences among active duty versus veterans with respect to sleep apnea. Among the active duty, it's been estimated that 20% of combat troops are diagnosed with sleep apnea, and this negatively affects military readiness. And of course, a lot of military operations operate under austere environments, makes it very difficult to prescribe PAP therapy for soldiers. I mean, they can't take it with them. And among veterans, it's the third most common chronic disease that's treated at the VA. And I think that's remarkable. It's the third most common. Over 1.5 million veterans with OSA, and again, 75% of veterans with PTSD have OSA. And those, of course, that have that combined diagnosis of PTSD and OSA are much less adherent to PAP therapy than with than compared to veterans with OSA alone. So if you have that dual diagnosis and you're treating this population, you're much less likely to get good results. So in general, how are veterans different than the general population? It's because our group of patients have this trauma-associated deep sleep disruption. They have that PTSD or traumatic brain injury. They have mood disorders. And all of these are contributory factors that prevent them to be fully adherent to PAP therapy. Okay, so in general, sleep disturbances are near universal among veterans with PTSD. And there was a study that showed that the frequency of sleep problems, as a veteran will report more and more sleep problems, that predicts an increase in their post-traumatic stress. And conversely, PTSD severity is associated with increasing sleep complaints, right? So that goes hand in hand. PTSD and sleep disorders are hand in hand. And it's not just OSA, it's also nightmares, movement disorders, insomnia, parasomnias, such as the night terrors that a lot of veterans have, cataplexy, sleep waking, wakeful dreaming, REM sleep behavior, and so on. So even among younger veterans, without the classic predictors of OSA, the classic predictors that we know about, such as being older or having a high BMI, they screen positive for OSA. So just repeating again, another study that showed 98% of veterans with PTSD have a sleep disturbance. And because of this, it's now recognized within the VA that routine screening of sleep disturbances has to occur even among the recently discharged veterans. It's not just the older veterans anymore, it's everybody. Everybody is needing to be screened for sleep disturbance. Now, what's the good news here is that if you treat OSA with CPAP, that's been associated with a decrease in nightmares and PTSD for this group of patients. However, because so many of these vets also have insomnia, they're having a hard time using their PAP unit. So that's a barrier. But it's so nice to see that you can make a difference in PTSD and nightmare occurrence with treatment of OSA. One unfortunate fact among veterans, everybody's heard about this, is the high rate of suicide among vets. It's overall the 10th most common cause of death in the US, but military vets have 1.5 times that rate, right? So prevention efforts have to target things that can modify that risk. And PTSD leading to sleep problems leads to suicide in some veterans. And so all the more reason to intervene early, right? So it turns out that another study showed that sleep clinic visits in the VA reduce the likelihood of suicide attempts among veterans. There is a per visit reduction in suicide risk of 11%. So for every visit to the sleep clinic, a vet who is at risk for suicide had an 11% reduction in their risk. And these are real facts. So it's all linked together, right? The PTSD, the sleep disturbance, and the suicide risk is all linked. So the VA came up with some unique ways to deal with this, and Dr. Gupta will talk about what came about, how did the VA deal with this, and how we're currently moving.
Thank you.
Yeah.
So I'm Jay Gupta. I'm the sleep surgery, sleep dental director for Vision 21, which is a regional program for sleep apnea. I'll talk about the structure of the VA on a future slide. but more particularly from a Vision 21 perspective, the region involves Northern California, Nevada, and Hawaii. And so our team oversees the treatment of surgeries and also appliances for those patients. So as Dr. Silva spoke about, the prevalence of sleep apnea drastically increased from 2010 to around 2016 in the VA system. And so the problem was, how do we bring sleep medicine services to more veterans? And the strategy was to start utilizing high-performance telesleep network in rural areas and pilot this program, which got funded in 2017. And so the Comprehensive Sleep Center would be positioned in a major city like, let's say, San Francisco. And from there, telemedicine, utilizing different structures like local VA support, telephone clinics, VTEL, video connect, remote PAP setup, travel clinics even where providers would go to different sites in different parts of California to deliver care. This was part of the Comprehensive Sleep Program. And together this was then called the Office of Rural Health, or the ORH Telesleep Program. There are studies on this that's been published and the overall sort of model, business model for this program. So again, in 2017, that's when the ORH program was established, funded from 2017 to 2023. And this led to a rapid expansion of telesleep nationally. And so this is very important because this allowed us to allowed veteran patients to have access to care, which before it was impossible because they had to go to the local sites for sleep apnea evaluation or diagnostic evaluation. But now with telesleep, our HST testing, that was now possible. So national purchase of 2,700 sleep testing devices occurred. Implementation, all this was done mainly by sleep medicine teams. And this program became really the proof of concept for our Vision 21 program. So again here, 2017 ORH program established. It focused on reaching rural veterans. It emphasized using telehealth, with or without deployment of travel teams. It sought to create a roadmap for intra and inter-facility telehealth. And so that allowed, rather than approaching things from a siloed perspective, allowed a lot of collaboration between VAs, such as us in San Francisco, Sacramento, Hawaii and Honolulu, even up to Reno and Las Vegas. And so this aligned the VHA priorities. So again, the idea from the VA perspective was to deliver care and make care accessible to patients. And so the telesleep program was really a first proof of that. The HST, again, rapidly grew in the VA system in 2017. And as a result, the PSG started to decline in the system. And so this slide here shows the green is really the 100% HSTs that were being utilized. So really California, other parts of the US, but mainly it was PSG. So that limited, again, access to care. So patients had to go physically to a VA center, get the test done, and then have either PAP or other treatments available to them. So with this ORH program, we're able to now use more HSTs. So again, a lot more patients got diagnosed with sleep apnea and got plugged into the system for treatment. So from the ORH came about the CRH program, and myself and our sleep director, Katie Sarmiento, put together a business plan that utilized all the resources within our Vision 21 to have a collaborative program for sleep apnea, which entailed dentistry, surgery, mental health, and medicine, which is pulmonary, neurology, and psychology as well, or psychiatry. So the vision was to optimize veterans' healthcare delivery through efficient utilization of personnel, resources, and innovative technologies to meet their healthcare needs. The mission was to modernize VA's delivery of exceptional veteran healthcare through shared regional services to overcome staffing challenges that contribute to inadequate access to healthcare and reduce disparities. So what is the Vision 21 program? So Vision 21 Sleep Apnea Program is a centralized clinical resource hub that coordinates and expands diagnostic and treatment options and streamlines program efficiency by incorporating technology and telehealth and establishing a virtual center of excellence for veterans with sleep disorders. So this brought about the hub and spoke model. So San Francisco serves as our hub. And so at SF, we have OMFS, which is me, we have ENT, we have all of our dental providers, we have sleep medicine, pulmonary, mental health, all stationed in San Francisco. And our spokes then are Sacramento, Reno, Las Vegas, and Hawaii as well. And so what this allows us to do is leverage our expertise and deliver care in different areas of these regions where those specialties may not be available. So the goals are to reduce sleep-related community care volume. So rather than sending patients out of the community, now they're brought back into the VA system, which reduces costs. And by reducing costs then we have, of course, more funding available for more personnel, more specialists, and more technology that we can utilize for our veteran patients. Create one VA experience for veterans. So that's been part of our marketing as well to the VA population. Standardized processes and workflows. So this has allowed us to be more collaborative. So a patient that comes in to sleep medicine or pulmonary or one of our colleagues, not all of them gets an oral appliance if they don't want CPAP, right? So this allows us to really figure out, is surgery the first line? Is it the appliance first line? A patient with a BMI of 40, maybe bariatrics is the first line therapy before we tried something else. So this has led to actually a lot of collaboration with the specialties and really good patient outcomes this past 2 years. The pandemic also has sort of streamlined and fast-tracked this ability for us to establish a CRH program and be more collaborative amongst each other with the different VA systems. So cost savings. So CRH in this past 2 years has definitely led to a lot of cost savings. So we've reduced bed days of care. So our surgical interventions are becoming more ideal in terms of VSP planning, custom cutting guides, custom plates, less surgery time, and that allows, of course, less ICU visits and quicker return at home. So reduction in community care, that's also occurred because of HSTs that have taken off. And that's been coordinated by our local programs. Greater use of HST I just mentioned, reduced clinical visits through virtual video conferencing. So a lot of my initial intakes with patients will be over virtual visits. So I'll see a patient sitting in Honolulu or in Reno or Vegas, do my full workup in terms of the surgery aspects, my craniofacial examination, all the sleep studies, all the data will be available to me that's been already processed by sleep medicine. And that allows me to then discuss in great detail all those surgical and oral appliance options while I'm sitting in San Francisco and the patient's in, let's say, Honolulu. And these different services are not available, and that allows that patient to have, again, these options available. So if an appliance is the way to go, they'll get outsourced to community care in Honolulu. But if it's surgery, then they'll fly into San Francisco and have Inspire or MMA surgery or phase 1 surgeries, bariatrics, whatever it is, and they come in and see us for that at our local program. So there's a lot of cost savings with that as well. So the VA is, again, the largest integrated healthcare system. There are 171 medical centers, 1,100 or so outpatient clinics, and it serves around 9 million enrolled veterans. So the VA structure is divided into VISNs. That's Veterans Integrated Service Network. So we are VISN 21. And again, VISN 21 oversees Northern California, Philippines, Northern Mariana Islands, Nevada, and also Hawaii. So within our catchment area in San Francisco VA, which Dr. Silva is our chief at San Francisco VA, we oversee pretty much the western part of the Northern California in terms of our dental clinic and our surgical clinic. So that's a full scope OMFS, full scope surgery that we oversee. But again, our sleep program is a hub, so patients from the other parts of VISN 21 will be sent to us for management. So this diagram here sort of shows that interplay between the different systems. Like for example, in Reno, we have one sleep medicine provider. Fresno has a half-time. Vegas currently has one. SF has 4. And so if there's, of course, multiple patients in Reno that are being booked out now, let's say 5-6 months later, the SF sleep medicine team can oversee some of the clinics virtually, which condenses the time and allows access to care for those patients. The surgical components, the They're stationed in Sacramento and San Francisco. So Sacramento has a robust ENT team, which I also helped set up the sleep program there. And SF has, of course, OMFS and ENT working together. So from the different sites in our Visit 21, if the patient requires surgery, then we will see them for telemedicine, telehealth visits, ensure they're a surgical candidate, come into these two different sites for our history and physical examination, all the lab testing, x-rays for that one visit, and then have them booked for surgery right after that. So it streamlines the process as well. The Vision 21 program this is the org chart for our structure here. So Vision 21 director is Katie Sarmiento, which I'm sure some of you have heard about. She's now our sleep medicine director for the entire VA system from Vision 21. So she oversees everything VA sleep related. And a lot of the protocols, management comes from her direction. So from there, there's the stakeholders in the VA 21, the Visit Sleep lead, there's the Visit 21 Sleep Committee, which I also sit on. And from here, we have the virtual multi-D sleep care team, which again involves all these components in terms of FTE. So my FTE is 0.25 in the Vision, and then 0.75 in San Francisco, so I do full scope in SF, but then my other hat that I wear is part of the Vision program, and I help oversee all the different sites for sleep dental and sleep surgery listed here. So the goals and the protocols in terms of management of OSA is really collaborative. So we want to have all specialties involved, from medicine, mental health, OMFS, ENT, general surgery from bariatric perspective, and dental for this really truly collaborative care. So our algorithm is that if a patient comes in for a sleep study with sleep medicine, they get their full workup, they're diagnosed with OSA, educational sessions happen with our various techs and nurses. From there, they get plugged in for a PAP trial, lifestyle modification, and possibly an oral appliance. So patients, 50% or so, are not candidate or they fail treatment with PAP, and so they come then to us as part of a multi-D sleep clinic. And again, this occurs both virtually and also at our local program in San Francisco. And with the multi-D clinic, from here, they can go on to then oral appliance, bariatrics, a DICE or drug-induced sleep endoscopy, Inspire nerve stimulator, MMA, phase 1 surgeries, go directly to an MMA instead, or go directly to nasal surgery and have more compliance with PAP. So those are the sort of ways we think about treatments of our patients. So the next few slides, I'm going to talk about evaluation of OSA, and then we'll dive into a few slides on oral appliances and also surgical management. But our diagnostic approach really involves clinical history taking. We talked about some of the different questionnaires earlier in a lecture, PSG, home testing, and of course, knowing your device limitations really helps in on honing on what the diagnosis for that patient really is for management purposes. So evaluation, nasal structures, Mallampati scores, looking at tonsils, looking at the occlusal classification, high arch palate, is it constricted? I'll look at facial thirds, making sure there's a good symmetry here. If not, then that tells me about either maxillary hypoplasia or hyperplasia, mandibular hyperplasia, and that affects my surgical protocols. Look at facial fifths as well in terms of symmetry, so we can correct that as we plan our various orthodontic or MMA procedures. I didn't mention also TMJ exam. So TMJ exam is a very important component of all this, and that's because we want to have stable joints when we do our facial reconstruction. And Dr. Silva will talk about more about TMD in relation with sleep apnea. So along with the clinical exam, we do CT scanning, CT and MRI, particularly for TMJs if they're an issue for the patient, and of course sleep endoscopy. So sleep endoscopy is done by both our service, OMFS, and ENT, and this is really for figuring out if a patient's a candidate for Inspire therapy. But I will use DICE as well for patients that have, let's say, mild sleep apnea, class 3 malocclusion, planning a Lefort. A patient like that, if they're found to have multi-level obstruction on DICE, then instead of planning just a Lefort, I'll do both a Lefort and a mandibular advancement to ensure that down the road they don't have recurrence of sleep apnea from a tongue-based standpoint. So treatment options, behavioral modification, pharm, airway devices or appliances, surgical options. I'll have Dr. Chui take over at this point. Yeah.
So after all that, the fun parts comes along. So at AVA, we do a lot of virtual visits, virtual consults with the patients. We'll see a lot of patients use video calls, talking to them a lot of times before we actually invite them to come to our practice, the clinic. So after we get a referral from the physicians, we'll do the consults and we'll go over all the medical history. We have the records of their x-rays, chromium CT if possible. We'll do a look over all the sleep studies and all the records and everything we do will go through follow exactly AADSM guidelines. And then we'll grant final decisions and have the patient to come to our clinic to proceed with their MAD. Sometimes the patients are so far away, we actually will fly them to San Francisco, give them accommodations and treat them. And so we'll evaluate the oral hygiene and also oral conditions to if we can do that, we do in a San Francisco setting. If we cannot, we'll outsource to private practices. So, and if those consults we cannot see the patients for oral appliance therapy, we refer the patients back for surgery and for other treatment modalities. Okay. Again, we use a lot of virtual visits for the patients. It's been great because we save a lot of time and energy to set up the appointment for the patients. It's really fast, really easy, and really quick. And we do a lot of follow-ups with the patients, call them up or talk to them on the phone or go over the difficulties and what they feel and how they see. Of course, you cannot see everything in terms of whether they have bite changes and things like that, but most of the time you can screen out, I would say 90% of the problems for the patients just by virtual visits. You really can cut down on a lot of resources because of that. It's been a game changer for us. And we utilize two different systems in the VA with two different software. CPRS, Computerized Patient Record System, which is the uniform global system that we share with all the physicians and all the healthcare professionals, the whole VA healthcare across the platform. And another one that we use is DRM, which is the Dental Record Manager, only for us in the dental setting. It's very similar to what we record in our own AMR for the dental side, but the CPRS, we will be able to see all the patient's healthcare history, all the records we can find. And the core, of course, we use this to record all the dental condition for the patients. We can also initiate any kind of consults for the patients within the system. We can talk to the ENTs, we can talk to the sleep physicians, oral surgeons, and for example, probably a month ago, we had a consult for a patient with TMJ problem. We took the CBCT scan around the ethmoid sinus. We suspect there may be some kind of expansion going on with the sinus, and we suspect that may be cancer. So we refer the patients back to the ENT to follow up with it immediately. It's so fast. Everything's on the same platform. And any healthcare providers can refer us patients as well. And we can also have access to all of state patients to access their record. And we also have some instant messaging system within the San Francisco network. And it's been really great. We have really great teams, supporting team within our office. And within our whole affiliated clinics, we have about 20 dentists and surgeons, 7 hygienists, 25 dental assistants, 7 administrative personnel, and 1 full-time lab technician. And they're all part of the sleep and TMJ clinic. It's been really great because you get a lot of support from everyone. And there are also some residents coming in for training. We have a residence program for oral surgery, PROS, perio, and GPR. And they also help participate for the sleep program. The clinic, we see about 15 to 20 TMD OSA patients for every TMD OSA day that we participate. So we get really busy. Also, education is a really, really important part of our program. We give a lot of hands-on practices and lectures on DSM, TMJ, and sleep surgery for the residents. And we have 4 residents every single year coming to our program after dental schools. And one of the main track is definitely sleep medicine. About 90 dental students are rotating from University of California, San Francisco, coming in for the rotations. And also from UCSF medical schools, we will see the fellows, sleep fellows, and also emergency medicine residents from the medical schools. This is mainly the non-surgical treatment and management, how we do in the VA. And of course, oral appliance is one of the major treatment therapy that we offer. We treat patients with snoring and mild and moderate sleep apnea, and also severe if patient cannot wear the CPAP and they don't want to do surgery. And we only would do custom appliances to treat the patients. We do all the sleep studies and also follow up with all the efficacy sleep tests. We do a lot of follow-ups again and again until the patient get the most optimal results. We don't have any bias to any appliance, but there's certain food types of appliance that we use because of the how easy is it to follow up with the patients. We do like certain appliance more than other. For example, we use a lot of prostaments because how we can follow up with the patients, how we can titrate them. We communicate with the sleep physicians. Say, for example, patients wearing you to L1. They will just put everything down there so we know right off the bat what kind of protrusion by your patients on, instead of calculating how many turns a patient's actually working on it. But we can actually calculate back with different types of appliance. But the sleep physicians, they're all well trained with these titrations percentage, how they can get to see how much protrusion we get for the patients. So it is something that we do a lot. We treat a lot of patients with oral appliance, and a lot of surgeons and a lot of physicians in the VA, they really favor the oral appliance therapy, and it gets us really busy. As the Philips recall we just talked about earlier, we got about 770,000 affected patients in the whole VA system. And so far we have no results or answer for every single one of them. And that shows a lot of them have funneled through coming back to us. And that's a lot of patients. And we also do a lot of studies and research, but we also pay a really strong attention to TMJ and also TMD with the occlusal changes. We treat a patient with TMD and sleep together, and it's really important. If something we cannot do, we also refer to other professionals to treat the patient at the same time. So now go back to surgical management for Dr. Gupta.
So from a surgical management perspective, thanks. So the goals are to, of course, the aims for sleep apnea surgery, reconstruct and restore form to allow optimal airway function and OSA treatment. So success defined as achieving AHI less than 20, reducing AHI by more than 50%. From a historical standpoint, the Stanford protocols really entailed this phase 1, phase 2 structure where patients underwent this UPPP, tonsillectomy, nasal surgeries, genoglossus advancement. If that didn't work out, then this phase 2 MMA surgery. During my training with Bob Riley, who really came up with all these protocols, this was really the way they would think about things. And over the past few years, a new protocol has come out where it's really evaluation of the patient, looking at the phenotype, which another lecture I talked about earlier today, and figuring out what really the patient needs in terms of treatment management. So we use a full clinical radiographic sleep endoscopy evaluation to figure out, do I really want to go to an MMA first? Do I want to go to Inspire first as an oral appliance instead? Is it a combined potentially Inspire and MMA patient, which we've done as well? So those are all ways to think about it. There's no set protocol that's been established yet either, because again, every patient is different, and the phenotype really dictates that. So this came out of the Stanford group, and I think this is really important that as we in the VA system have also adapted this in our own sort of thinking process with our own experiences to working with different specialties. So historically, again, phase 1 surgeries, just if you want to bundle things together, are thought about in terms of nasal surgery, tonsillectomy, expansion pharyngoplasty. I don't do UPPs because of potential contraction and scar formation with that, but instead expansion pharyngoplasty can reduce concentric collapse to more AP collapse, which makes the patient compatible with Inspire. So I do that instead. Of course, SARPI procedures, nasal procedures, genoglossus advancements. We're using a lot of VSP 3D printed guides and plates that makes our surgery very accurate and precise. And I'll show a case about that too in a bit. Phase 2, I like to think about it in terms of MMAs, also Inspire nerve stimulator, and patients that have both TMD and sleep apnea, which Dr. Silva will talk about. A unique patient that has severe TMD and severe OSA can be treated with bilateral joint replacement and MMA advancement surgery. So we do that routinely too as part of our group. So upper airway stimulation, I know Pat McBride is going to be here from Inspire, I believe tomorrow, so she'll give more information about this. But there's a lot of good studies out, 6 years plus, indications adults 22 years or older, AHI ranges from 15 to 65, PAP failure, appropriate airway anatomy based off DICE, so if it's a concentric collapse, they're not a candidate, if it's AP, lateral, they are candidates for Inspire. Our group between Sacramento and San Francisco, we've done close to 70 patients now. Really good results with Inspire. Contraindications, central and mixed apneas more than 25%. Again, concentric collapse, neuromuscular disorders, psychiatric disease. Dr. Silva talked about PTSD, so that's something our patients go through a mental health evaluation before we do something like an Inspire therapy or MMA surgery. And even bariatric program has a very detailed mental health assessment too, so that's part of our program. Upper airway stimulation with DICE findings. So again, this is a AP collapse. A circular concentric collapse means that the patient is not a candidate for Inspire. Generally speaking, we're looking for the hypoglossal nerve, looking for the inclusion branches, which pushes the genoglossus and genohypal muscles down and forward, and exclusion branches, which would target these muscles. We want to exclude that from the actual stimulator device. So this past year, we've been doing the 2-incision technique. Before that was a 3-incision technique. So the 2 incisions now involves just a neck incision and one along in the chest wall above the pec muscle here. And the sensor lead now is placed below the battery between the ribs with this 2-incision technique. So the activation process occurs typically 1 month after surgery, and the patient escalates the thresholds on their own using the remote device. And then we get a titration PSG. Now we've moved towards a home testing instead of PSG, so it's become easier. I've done patients now from Idaho. They'll come in for the Inspire device, I'll implant it, 1 week follow-up, and then everything's done remotely now through HSTs and just remote virtual visits. So this is becoming more powerful using virtual consults. The Inspire team also is heavily involved in this process pre and post-op, and they've been really phenomenal and fantastic in taking care of our patients. Another slide just showing no stimulation on, you have collapse of both the palate and base of tongue, and then with the stimulation on, this is how the palate and tongue base moves. So a lot of good studies out now with Inspire in terms of efficacy and outcomes, and we're using now in pediatric patients as well. So from another surgical management perspective, we also do MMA surgeries in part of our team here. So MMA surgery is indicated for severe sleep apnea, a multi-level collapse of the airway, and really hypopharyngeal narrowing. So I like to think about MMA surgery as a multi-level sort of expansion of the skeleton, and this affects everything from the nasal structure to the upper jaw, lower jaw, the epiglottis, the hyoid bone. Everything is affected by the MMA surgery. The airway structure we talked about, and MMA outcomes. There's many articles published from Bob Riley, Powell, Shandell over the past 20, 30 years showing the efficacy of MMA, the stability of it, the good outcomes long-term as well. This is one of our VA patients came in with a class 2 malocclusion, retreated upper jaw, lower jaw, AHI of 38, his lowest O2 was 86%. And this case was completely done with guided surgery. So we used, we've got a CT scan, we got his intraoral scans, merged them together. We used different companies like Stryker, Kalis Martin, who then we partner with a VSP. We then figure out how much of the upper jaw and lower jaw to advance, how much counterclockwise rotation to build in as well from an aesthetic standpoint, and then we fabricate cutting guides and plates. So again, it's all precise. And in our team, we also use cutting guides and plates for the mandible, and we're in the process of publishing an article that shows by using custom cutting guides and plates, the condylar position has not changed pre-op and post-op. And that's really important too, because if the condylar position changes, you set the patient up for TMD issues down the road, and that can lead to also relapse of the MMA structure as the TMD progresses.
Oh, thanks. Okay, so I've been at the VA for over 25 years, and I started off as a TMJ surgeon there, but I had to do a little bit of everything as the only oral surgeon at the VA at that time. And now there's 4 of us full-time at San Francisco VA. But I'm still a TMJ surgeon at heart, and I'm so glad now that my work is dovetailing with Dr. Chui's work and Dr. Gupta's work. And but I always think about TMJ and my sleep patients. The relationship between TMD and OSA is not fully understood. There's information showing that TMD directly can cause OSA through anatomic changes. We know this. Myofascial pain is associated with elevation in sleep fragmentation and increased RERA events. 52% of mild to moderate OSA patients come with pre-existing TMD. And there's also another study that showed a few years ago that there's a relationship between TMD and upper airway resistance syndrome. The relationship between sleep bruxism and sleep disordered breathing is also there, although we don't know if one causes the other or vice versa. That causal relationship hasn't been established yet. But we do know that untreated TMD can lead to MMA instability and failure because the joints will continue to resorb and the mandible undergoes that clockwise rotation. At our clinic, we do conservative measures too. I don't want you to think everybody's getting TMJ surgery, but I'm doing a lot of Botox. We all do steroid injections and orthotics. We have Dr. Chui for that too. We're doing arthrocentesis and arthroscopy, and even just disc surgery just related to putting the disc back to where it's supposed to be before we move forward with MMA. But we're also doing a lot of total joint replacement, and within the VA system, we've become, at San Francisco, a center for total joint replacement. And I was fortunate enough to co-write and co-edit 3 textbooks on this a few years ago with some of my colleagues. And I'd like to just share a case that we're doing. But other options, of course, and my focus is here under custom or stock total joint reconstruction with post-op PT. We have, pain clinics and psychiatric mental health assistants and a lot of TLC for our chronic pain patients. These are just some of the other things that we're doing. Pills, lots of pills, splint therapy, PT, and Botox for those with muscular problems alone. Some of our more conservative management here, Botox, hyaluronic acid injection into the joints, pills and patches, and so on and so forth. Okay. So just going to highlight one case where patients, because our patients are older, our patients are predominantly male at the VA, as you can imagine, and because of lifetime bruxism and maybe service-connected jaw-related injuries, end up with a lot of TMJ problems and degenerative joint disease. And then develop sleep apnea. And what do you do with these patients? They have high, moderate to severe sleep apnea. They have coexisting TMD, and these vets with that dual diagnosis are a big problem. So our protocol now is to do this VSP, virtual surgical planning. And the first step would be to plan virtually the movements, the surgical movements that we want to undertake. So we've got maxillary advancement, and you can see here in this scan, this 3D rendering, that the joints have been cut off because we've already determined that there's so much pre-existing degenerative joint disease that we're going to replace those joints. And the mandible and the maxilla move forward. Of course, the maxilla is a traditional Lefort osteotomy, and the mandible is going to come forward, not with sagittal split osteotomies, but with the joint replacement. Some planned changes on our Ceph and how we're going to alter angulation and position of the jaws. And then once we have determined where we want to put the jaws, now we're going to address the joints and how we're going to rebuild those joints. So again, virtual surgical planning to figure out where we're going to make our cuts. And then we turn that information over to this company, TMJ Concepts, now owned by the Stryker Corporation. They're the only company in the United States that is FDA cleared to make custom TMJ prostheses. They're located in California, Central California, down on the coast in Ventura. And they're real busy. They're an international company as well, making probably on the order of 1,500 custom joints a year for their customers in the US and internationally. So you can see here that using a 3D model that's been constructed from that virtual surgical planning, we plan the shape of our joints. So we go from a plan here to fabrication of a custom appliance, and you can see this little kind of gooseneck advancement. That's what's going to give us our really rigid strut to bring that jaw forward. So here we're trying to solve two problems at the same time, the degenerative joint disease and the OSA. There is also a custom fossa that has a polyethylene, it's titanium mesh over here, and ultra-high density polyethylene fossa. It's the same material that's used in hip replacements and in knee replacements. We use it in TMJ replacements. And then our final result will be a lot of hardware. Okay, I realize that there's a lot of metal here, but we have our advancement with custom fabricated Lefort 1 osteotomy plates, and the advancement, the mandibular advancement with the TMJ Concepts custom joints. And you can see actually, even on this Ceph, which is fairly immediate post-op, how big the airway is here now. It's really opened up. Okay, and some of our results here with total joint replacement, preoperatively and postoperatively. We make sure that the patients go and get another sleep study, and we can see Epworth score dramatically decreased, respiratory disturbance index goes down, the maximum size of opening goes up, from somebody who was opening 27 millimeters before to 43. TMJ pain is gone, and the DICE shows no restriction in airway. Okay, you want to talk about some of our projects?
Yeah, so at the VA we also have many different research projects that we undertake. One of our other surgeons is PhD, heavily involved in research as well, and some of our projects are involved in TMJ, CFD analysis, condylar positioning that we'll talk about as well, oral cancer, new protocols in ORN patients that had radiation that Dr. Silva, myself, and Dr. Conley have developed. Simulation is a big part of our program, which is a national program as well. And a lot of these projects are done in collaboration with UCSF and other colleagues in different departments. So this is one project that's undertaken right now at the VA. It's in collaboration with the University of Cincinnati. We're looking at dynamic airway changes in patients with and without the oral appliance. And the CFD analysis is done with a CT scan. Patient is also induced sleep, similar to a sleep endoscopy. I'm doing a DICE on the patient, and we also then scan the patient, and we've done now 2. So data, of course, has not been analyzed yet, but the CFD analysis, the goals are to show that different parts of the airways are changing, utilizing different types of oral appliances. And so how can we figure out the different phenotypes that are affected, and then figure out which appliances, which surgeries are more ideal for that patient based on that phenotype. So that's the goals of this project. Again, this one's we just submitted for publication, looking at custom-made cutting guides and plates for the mandibular advancement in MMA surgery. This has not been reported in literature yet, and this, we showed that our VSP planning with the condylar position was the same pre and post-op. And so once we make our cuts, the mandible is advanced. Traditionally, we clinically position the proximal segment using an instrument to figure out where the condyle should go, and then plate the segments together. And sometimes when you then release the IMF, the occlusion's off a little bit. So you have to go back and replate and redo it. This is now ensuring that the condyle is in the same position pre and post using these custom plates, and it also shaves off time in terms of our surgery. Another project that we're doing is EpiBone with MMA surgery. And Dr. Sim can talk about that.
Yeah, this is a very exciting project that I'm doing right now. It's a multi-center study, and working on my second patient now. But EpiBone is a company in New York, was a startup about 10 years ago, and they developed a technique for growing custom bone that's genetically identical to you, and it's all done through a liposuction from belly fat. And how it works is I send them my patient's lipoaspirate. They derive the mesenchymal stem cells, and based on my VSP, they know exactly how much bone I need to advance the jaw. So this was actually my first patient. Severe sleep apnea. We want to advance the jaws. We want to do MMA. And what I did was I designed an osteotomy, but instead of a sagittal split, we enrolled this patient in the EpiBone study and grew custom bone to put in there. The company uses this bioreactor to grow the cells and ship me overnight a live piece of bone that I implant into the patient. So it's just another way to dovetail my work with other surgical work that's going on. And here's that piece of custom bone. That's the exact size and shape that I needed to implant to bring that jaw forward. And we're getting ready to do our second case now. So this is actually kind of an aside, but it's going to change the face of reconstructive surgery, being able to grow your own bone instead of taking bone from your hip or from some other part of your body. In reconstructive cases, one day soon, we're going to be able to just take a little fat from your belly and grow the piece of bone that you need. And the first application of this work is in the maxillofacial arena, although it's going to obviously be expanded to other orthopedic applications. So there's the custom cutting guide. We did this case extraorally because I wanted to make sure that that little piece of living bone wasn't going to get contaminated with saliva or plaque or anything like that. And we did our custom cuts and put in the bone. You can see, let's see if I get my pointer right there. That's the little piece of EpiBone that went in perfectly. That was the predicted hole or osteotomy where it needed to get dropped in. Oh, actually, that's the cut. I'm sorry. That's the cut. Here's the advancement. And you can see we brought the jaw forward quite a bit. And in here, the epibone is in here with the plate in place. So on this patient, one side got the custom bone. The other side was a traditional sagittal split. My next patient is going to be bilateral epibone. So just another way of doing an MMA. All right, and I'm going to now segue to this because at the VA, like I said, there was this explosion of cases. And I don't know if you all know, but not every veteran is eligible for dental care through the VA. It turns out maybe it's about 14% only. And there's very strict guidelines I don't have to get into here. But what do we do for these sleep apnea patients that need oral appliances? Initially, our guidance was, well, only people who are eligible for dental care can get these oral appliances through the VA. And as more and more sleep apnea patients started showing up, the VA changed their mind. And in 2017, the Deputy Undersecretary for Health for Operations and Management came out with a memorandum that said, basically, VA dental services around the country, you cannot turn people away for oral appliances just because they're not eligible for dental care. And that opened up the floodgates, and every patient who wanted oral appliance or who was indicated for oral appliance was able to come to the VA dental clinics to get that done. But that soon overwhelmed our ability to do so. And even in our clinic, we're getting to the point where we can't handle it anymore, even though we have Dr. Chui, thank God for Dr. Chui, and some other colleagues that are doing this work. We actually don't have the physical capacity, enough rooms, enough treatment rooms to get all of these patients done. And so, and that's at a center that focuses on this work. You can imagine at different VAs around the country, there just simply aren't enough providers who are trained or have the expertise or even the time to deal with all the patients that need oral appliances. So this memorandum in 2017 gave us the ability to fee people out. And so the community care program opened up for us to be able to send patients to community providers who do have the expertise and the bandwidth to do this sort of work. So how do we do that? There's two ways to participate with the VA in patient care. One is to become an on-site provider, like Dr. Chui and others who are in private practice but are now also working part-time for us at the VA. And he has his own clinic, and I've hired a total of 4 people like this who come part-time. And we call that a fee basis provider. They come into the VA, we pay them essentially per diem, and they do this work on a schedule. Or we have staff providers, obviously, who are full-time VA staff. Or you can become a community care provider through in-network participation. In the western half of the US, there's a third-party provider called TriWest, and one has to enroll with TriWest if you're an outside provider that wants to offer these services. In the eastern half of the US, it's another third-party provider that's called Optum. But if there's people that are interested in being in-network providers with the VA, you would basically enroll yourself with either TriWest or Optum, depending on where you are, and say that you want to be able to become a VA community care provider. Basically, you want that particular program that TriWest or Optum administers. All right, Now, if you wanted to be an on-site VA provider, assuming that the VA has room for you, I've already run out of room, that particular VA dental service chief, like in other words, my colleague maybe at another city, would need to justify the need for such an employee, whether a staff or a contract fee basis employee, to come in and get the money, get the funding. This is what I did. And then the medical center leadership approves the position. And then you have to get credentialed through the VA. That means that includes background checks, or it's a federal facility, so you go through an FBI and Department of Justice background check, verification of training, and you get privileges. And then you come to some agreement with the dental service chief, your time commitment, your hours. Clinic time is established. Patients are populated into those slots. And basically the VA assumes responsibility for getting you all the instruments and materials that you need. You don't need extra malpractice insurance. When you come work at the VA, you're covered. And you write your notes within the VA system that Dr. Chui was talking about, the VA's electronic medical records system. So that's becoming an on-site VA provider. For community care is allowed to be authorized. I can send somebody out to the community if A, I don't offer the service in my clinic, or B, I offer the service, but I can't offer it in a timely way, and that's the barrier that I'm coming up across now. Or C, if the patient lives more than 90 minutes away, one way, from the nearest VA offering that service. So my VA, San Francisco VA, has a large catchment area that basically goes from just south of San Francisco all the way to the northern border of California, practically Oregon, and on the western half of California. And so patients that live way up there, like Eureka, California, they're 6 hours from San Francisco. It's just not practical for most things to bring them down. And by the way, the VA will fly, we were talking about patients that are coming from Hawaii and Boise and Reno and all that. VA flies them in for surgery, but for stuff like dental care, if they're eligible, or OSA appliances, it's more cost effective if we do fee them out to community providers. It's very hard to take a hours-long trip to your nearest VA that offers that service. So if somebody meets these criteria, that we don't offer the service, or we can't offer it in a timely way, or they live too far, I'm allowed to fee them out. From my current barriers and barriers that we have around the country is that there are not enough providers who are in network, right? There's not enough of y'all who are signed up. And because of that, there are still delays. Yes? Okay. There's still delays in care. How it works is this. I know this is a very busy slide, but the VA will, let's say a sleep medicine provider refers a patient to us, right? They meet criteria for a oral appliance. First thing we do is determine whether they're eligible for dental care, because we need to know that. Secondly, do we think that they meet criteria for an MAD? Now, if they do, we want to know, do they need some dental treatment prior to that or not? All right, if they don't, then they're ready for their mandibular advancement device, and we get it done if we have clinic capacity. If we do, then we proceed with treatment. If we don't have clinic capacity, I'm allowed to refer to an outside provider. Now, suppose somebody is indicated for a mandibular advancement device, but they need some dental care ahead of time. Then I need to know, are they eligible? That's why we determine that eligibility. And if so, then we complete the dental treatment. Then they're ready for their device. But then the same question, do we have clinic capacity or not? And if not, we refer to an outside provider. If somebody is not eligible for dental care through the VA, which is a lot of our patients, then they have to get that done on their own, on the outside. And they have to go to see their own dentist. And then, do we have the capacity to do their device in-house? If not, then I'm allowed to send them to a community provider. And that's the algorithm. Community care within the VA is authorized in something called a SEOC, which is a standard episode of care. And it's like a package deal. Within that standard episode of care, that includes OSA. Now, it's not under the dental standard episodes of care, it's always under the medical. So if a patient gets referred to the community, they're referred under a medical SEOC, a medical standardized episode of care. And it includes the evaluation and fitting, and it includes the appliance. So what's approved under that is the consult or the exam, any x-rays you need, and the actual appliance. But under medical codes, not dental codes. So the SEOC covers the care done by a dentist, but it's billed with medical codes. And the community care network contract specifically allows for payment of the device, right? So this is what would happen if the particular VA does not have the capacity to do it. Right? There's still challenges because there's just not enough people who offer this service. And coordinating care with outside providers is a challenge too. You know, someone on the outside doesn't have access to the medical records that I have access to. I don't have access to their office notes. You know, so there's a problem, and the demand for this sort of care is definitely outpacing our ability to provide it. So there's still a lot of challenges ahead. Okay, Chewy. That's his VA badge.
Yeah, I know, Ellen, when 5 minutes, I'm going to run through it really quick. I started working in VA about 2.5 years ago. It's been great. I don't go there a lot. I go there probably twice a month, and it's been really rewarding. And I look forward to going to the VA every time I go there. So much more support, so much more relaxing, no drama, no staff issues. So you guys all know how it is if you have private practice. So we work with highly trained clinical assistants. They are very knowledgeable, and they help me tremendously in terms of training patients. And a lot of great support professionally from other colleagues. And you got to teach the residents, and there's no insurance form, no complications in terms of the paperwork. And we got to use any type of technology we want to. If you want, we talk about it, we have the budget, we can buy it. So we are not restricted by the local judiciary. It's completely separate from the state guidelines. So we use our own guidelines to follow up with the federal guidelines.